Welcome to the Medical Support to Irregular Warfare podcast, an initiative to discuss and educate the evolution of medical support in peace, security, and conflict in uncommon environments. Points, perspectives, and opinions voiced here are solely those of the contributors and do not represent any formal association or government entity. We do everything possible to ensure the information and discussion is sound, comprehensive, and from the most credible sources.
Welcome back to the Medical Support to Irregular Warfare podcast. My name is Marty. I'm a member of the MSIW Committee of the Special Operations Medical Association, and this is another in a short series of MSIW podcasts focusing on irregular warfare medicine in the Pacific. Today, I'm fortunate to have a couple of physicians from Australia joining me. I've got Dr. Tom, who's a trauma surgeon, and Dr. Marty, who's an anesthetist. And I'm going to let both of them describe a little bit of their background and how they got interested in this subject matter. And then we're going to enter into a discussion about surgery in the unconventional warfare environment. Good day, gentlemen. Please, Tom, can you describe your background? Tell us about yourself.
Thanks, Mark. Look, not a huge amount to add from your introduction there. Trauma surgeon, background in the military, and particular interest in military history. At one of our conferences, the Australian Tactical Medical Conference a couple of years ago, had the privilege of hearing a presentation on unconventional warfare by Mike Hetzler. And that opened my eyes to a few things that I saw some pretty clear parallels between our past, this Australian history of working in the Pacific, and some of the future problems. And I got chatting with Marty, and we ended up giving a presentation on that topic the next year at the ATMC.
Marty, please introduce yourself.
Hey, Mark. Marty, I'm an anaesthetist or anesthesiologist, as you Americans might term it. In Australia, I did my medical training under an Army scholarship, so I did a bunch of time as a junior doctor with the Australian Army before I started doing anaesthetics. Deployed a couple of times with the Australian Army, both as a junior doctor and as a anaesthetist. Yeah, as Tom said, I've got a bit of an interest in military history, and so spend a lot of time at our Australian War Memorial. And Tom and I have both researched this topic, looking at surgeons and anaesthetists accounts from the time. There's huge boxes and boxes of accounts written from the guys that our forebears during World War II, as well as journal articles in the Lancet, the Australian Medical Journal at the time, talking about their experiences and what they did. And so that's where we've got a lot of this information from. And we were sort of thinking, look, the stuff that we've learned over the last 20 years of conflict, we've had huge advances both medically, surgically, resuscitatively, but how would we utilize that knowledge going forward if we were put back into a situation like in World War II, either on the Kokoda track in New Guinea, in a prisoner of war camp, in some of these smaller teams looking after partisan forces? Could we utilize this knowledge? Would it be useful at all? And we came out with a few ideas, as Tom said.
That's fantastic. And I was fortunate enough to be in the room when you and Tom gave that presentation at the Australian Tactical Medicine Conference in 2023 on surgery in the UW environment. Brilliant talk. And I hope to spend a fair bit of time listening to you cover down on some of those points again. So if we can start off with this question, then I'll let you guys just riff on this. If we're talking about medical support to irregular warfare, that encompasses a number of different subsets that fall under that umbrella. Unconventional warfare, counterinsurgency, foreign internal defense, counterterrorism, some forms of security assistance, a couple of other collateral mission sets. That's based on current U.S. doctrine. And understanding that some of our allies and partners may have a different view on what irregular warfare is. But can I get you to start off by elaborating on those differences between what we've learned over the last 3 decades of doing both forward and austere resuscitative and surgical care. And how do we take that information, those lessons, that institutional knowledge, and how do we transfer that into the irregular warfare environment?
Yeah, look, thanks, Mark. It's a big question, obviously a big answer for that. I think where we stand, and there's a lot of people that are still looking at military medicine in this regard of damage control surgery with massive amounts of blood products, damage control surgical techniques, so temporizing surgery with packing the abdomen in order to stop bleeding, stop contamination, and then a critical care phase. And that has saved substantial people, but it comes at a cost. Like logistically, it's massive. You need to have all of your medical systems in place and well trained to be able to do that. It relies on aircraft support in order to get patients to you very quickly and evacuate the patients, because if you can't evacuate them rearward, you end up with a whole heap of critical care patients that your team is now unable to look after. For instance, in Afghanistan, the difference between earlier on versus when we were a full-blown medical system in the 2014, 15 sort of era, which is sort of, I can probably talk on that. I can't talk about later, but the difference was marked. And that was because of we owned the airspace, so we could get patients to us within half an hour, to us as a surgical team, and we could get them out of there back to Australia or back to the US, where they could continue on their long progressive treatments and rehabilitation. In this space, we don't really have that option. We don't necessarily own the airspace, so patients could take days, weeks, months to get to us, and we don't necessarily own the airspace to get them out of that nation. So if we do something like we were doing towards the end of Afghanistan and throw massive amounts of blood products at them, intubate them, ventilate them, and then have them in an intensive care type unit, we don't have the manpower, the logistics, or the evacuation to be able to achieve that. And so we'd be stuck with this patient, hand ventilating them and giving them adrenaline or epinephrine, as you guys would say, bumps rather than running infusions. So that's sort of where we're coming from. I guess stepping on those different forms of irregular warfare, where we would fit in, there's a lot of different ways that we could fit in a surgical team into that space. The hardest one would be unconventional warfare, I think, because it's, a contested space, a much more contested space. But, a surgical team could do some work in all of those areas, both as a way of soft power to improve relations with the host nation, as well as training up host nation assets and learning from host nation's assets, so that if it did go louder to a more conventional space, now Australia has a little bit more medical knowledge in that area.
I think that most of our audience is really fascinated by how we employ medical support in the unconventional warfare environment. Can you elaborate, as a trauma surgeon, on the difference between, as Marty says, damage control surgery pending the evacuation of casualties back for recovery and rehabilitation, and put a spin on that in the environment where evacuation is either going to be delayed, or for some of our casualties, there will be no evacuation. They're going to have to be recovered and rehabbed on site.
Absolutely. So I guess I could start by saying I perceive my clinical job to be stopping bleeding, right? With a secondary goal of limiting or minimizing contamination. If we look at those two things, like if you're casually injured in battle or in war and you're bleeding, you will die quickly if you're bleeding. And I'm looking right now at Stacey Shackelford's paper, The Golden Hour of Casualty Care, came out a couple of years ago. I had the pleasure of meeting Dr. Shackelford at the ATMC a couple of years ago as well, where we discussed her research. But There's a pretty clear finding here, and this is based on the JTS data from the Middle East over many, many years, some of the best data we'll ever have possibly on injury. And 2/3 of the people who died from that conflict died in the first hour after being injured. And that's because if you are losing blood from your vascular system, if it's fast, you're going to die quickly, right? And then there's a paradoxical thing, whereas if you don't get to a surgical element of care, or if I'm talking about non-compressible hemorrhage with surgery in particular, but if you don't stop that bleeding within about, say, two hours, then 90% of the people who would have died will have died. So if we start talking about unconventional warfare or any of those types of irregular warfare that you mentioned, where there's clear issues with moving people and high resource resuscitation and surgery, you're in a world of pain if you're bleeding. Now, if we look back through history, damage control concepts really only developed in the 90s. Mike Rotondo's seminal paper on that topic came out in the early 90s, 92 from memory. And our forebears, like our grandparents' generation who were fighting in these environments and providing medical care in these environments, had no access to the concept of damage control. So we haven't had a period of warfare where we've known about damage control theory, medically, I mean, and had something like this to deal with in recent memory. And I'm talking, I guess, large scale combat operations type work or UW in that environment. So this is an unknown, I guess, medically. Now, just what I've picked up on from many of my experiences doing training is that I completely agree with Marty that damage control resuscitation, damage control surgery are somewhat misunderstood. A lot of people think that it's low resource because you're doing quick surgery, and it's actually possibly some of the highest resource surgery you could possibly do. And many people would argue that without a functioning intensive care unit, you actually can't do damage control surgery. Damage control surgery plugs into damage control resuscitation, meaning you've got a critically injured person, and if you need damage control, you're by definition one of the worst of those critically injured people. You're starting to go down that vortex of death. The lethal diamond is affecting you. You're at risk of coagulopathy and non-surgical hemorrhage, and therefore need something done quickly. So if we're training this, and certainly through the GWAT era, that was the doctrine, and it definitely works. But if we're looking future focused, specific, theoretically UW environments, we're not going to be able to do that type of surgery. It's simply, we won't be receiving those types of patients. I'll just say one or two more things. If we look back, Lindsay Rogers operating in as part of the Yugoslav resistance in World War II, some of the things he focused on in his writings were nutrition and pressure care support and evacuation of people on trains. Now, all this stuff we might see it as nursing care, but it's good medical care. What it says to me is that the sort of people that he was operating on was not these massively bleeding people. It's wounds, it's burns, it's fractures. So you're looking at a totally different subset of people. Throw it back to Marty.
Yeah.
To say, or?
I think that's exactly it. The fact that, we can't really do the damage control that we've been doing for the last 20 years or the last probably 5 to 10 years of the war on terror, but we're not going to have to do that because the patients we're going to see have already had that trial of life. They're going to be getting to a surgical team probably days, maybe weeks, or perhaps even months after injury or wounding. But we're also going to be seeing the standard emergency surgery stuff that we're seeing in hospitals and humanitarian assistant teams are seeing, such as your incarcerated inguinal hernias, those sort of stuff that are occurring in debilitated malnutrition patients. You're going to be seeing those sort of things, and so this type of surgery probably has a lot more in common with what Médecins Sans Frontières would be seeing as opposed to what the Role 3 surgical team in Afghanistan was seeing circa 2012 to 2015. Now, that doesn't necessarily mean that you won't see major trauma, like that still can occur, but I think because you don't have that back end support of the logistics and specifically your evacuation, your strategic evacuation backwards, you've got to then look at what surgery is possible, and perhaps do a modified technique. So instead of doing, say, Tom was talking about controlling contamination, whereas he would maybe, with a gunshot wound to a large bowel, he might staple that bowel closed, pack the belly, temporize it, and then go back and do his proper repair 12, 24 hours later. In this situation, you might not get a chance to see that patient. So if you leave the patient with a piece of bowel that's not connected up and you don't get to do your second stage laparotomy, they're going to die. So you need to do a proper operation that has less chance of failing. So maybe doing a ileostomy, patient then has a bag that they've got to deal with for the rest of their life, but at least they're alive. So maybe we do a sort of a modified, using those lessons of damage control surgery, but rather than doing temporizing measures, we complete the surgery.
I'm curious of your viewpoints on this, especially since you both have made it very clear to me that you're passionate about the military history of your colleagues that went before, who learned these lessons in places like New Guinea or Thailand or Yugoslavia or southern France in World War II. But I'm really curious about that first phase, the Roll 1 phase, from point of injury until they can get to some form of forward surgical care. What are your thoughts on the proliferation of prolonged casualty care training amongst those people who will be at or near point of injury, who will be taking care of folks in the Roll 1 phase, admittedly with potentially a long period of time before they can get their casualties to folks like you? But what role does PCC have? Is that going to make a substantial difference based on the training that's available and is being adopted worldwide now versus what our predecessors had in World War II?
Yeah, I think Grummers spoke a bit on that with you. Yeah, but it's going to be vital because there's potentially going to be a prolonged period before the patient gets to those medical providers that can do prolonged field care. So they already have a trial of life. So maybe we even need to improve that training to individuals. So if you look at, I guess, what's happening in Ukraine at the moment, there's the buddy aid with guys in trench warfare having to sit on patients before they can actually get to a trained medic to evacuate them to a surgical team. So I think we've got to expand that a little bit, and the trained medic, forward doctors that are doing this prolonged medical care, they're going to have to probably hold patients for a lot longer than they would have in the past. So we're going to have to up their medical knowledge. We're going to have to look at logistics for that so that they've got enough equipment. The old days of the global war on terror, towards the end, we had medics going into direct actions with very, very small medical kits because they knew that a helicopter would come and scoop them and get out of there. So they might get an antibiotic, but if they missed the antibiotic, it wasn't such a big deal. Now we're getting to the stage where they might be holding on to this patient for days. And so having enough antibiotics is going to be vital, because if they don't have those antibiotics, the patient's going to end up septic and won't make it to a surgical team.
Yeah, I guess because what we're talking about is the military context of the medical care is so important, because it's all totally different between different contexts. And like when you're training these military medics, and obviously I focus on the medical side of training, but it's very hard to get people to understand everything in terms of we'll prepare for all these different types of missions and you use your same medical knowledge for each. one of the things that does worry me is when you have such good training in resuscitation care for badly injured people, I can see that making decisions quickly in the forward environment, in particularly in a UW or any type of regular warfare situation, could be very tricky. And what I'm trying to say is, it stresses me that people will be injured and our medics will be pulling them back, and that person might be someone who's going to have a futile treatment outcome. So these people who are badly injured, bleeding, terribly burnt, it's pretty hard to make the decisions in the forward environment about preempting a clinical course. But what we're seeing overseas at the moment is that the actual evacuation part of the care is highly risky to these forward medical elements. And we need to empower our people, or not necessarily our people, we need to empower forward medical providers to make good decisions about when to move and when not to move. And if you're not going to move and you've got a badly injured person, there's a lot of implications on that. There's potentially huge amounts of moral injury if people are making decisions based on limited information about people's lives. And all I can do to help that is to medically empower people with knowledge, because it's highly unlikely that you're going to have specialist doctors in a far forward environment. And then the next bit of it is looking at, so you've made a decision about whether to evacuate or not evacuate. If you're not evacuating and people are dying, we need to be thinking about palliative care in forward environments, which is a whole another topic, something that probably has not been focused on very well in the last 10 to 20 years because of a lack of necessity. And then we're also thinking about prolonged field care. I'm a huge advocate of prolonged field care. I think it's the way that we should be training. Definitely, it's the way that I've been trained. And there's a lot of things that aren't so, it's a bit different to the way that we train the trauma stuff. It's looking at stuff that all patients need that will prevent future mortality, future morbidity, things like all the things we focus on. I won't list them out, but I think I heard a really good quote at the last ATMC by one of our senior nursing leaders. And she said the quote that prolonged field care is good nursing care. And I initially thought, well, I guess that's pretty true. And I'm sure the people that are listening who are trained in prolonged field care may have their own opinions on that. And I'm not necessarily saying that it's doctrine, but I think there's a lot to say in that. And training those basics and empowering people with that knowledge is going to save lives.
Yeah, every bit of PFC and PCC training that I've been involved with, that's been an underlying theme is nursing care is underappreciated and so critically important.
Yeah, sorry, Mark. On top of that, like the area that we're looking at the Pacific area, and we haven't been exposed to this for a while, but that comes with a lot of issues with diseases, tropical environment that we didn't see in Afghanistan, and that in itself puts extra strain on things. So when my battalion was in East Timor in '99, we had significant numbers of falciparum malaria that were required to be treated because the environment itself, we had a lot of East Timorese coming back through our area with limited ability to protect themselves, and so had a lot of diseases, a lot of tropical diseases in that population, which then spread to us. And because of the security environment, the guys weren't able to protect themselves at night with mozzie shields, etc. They were in, they were on. They were in overwatch positions, etc., and so being bitten and getting a large load of parasites. And then, of course, when we came back to Australia, we had, I think, about 150 cases of Vivax malaria in those groups. So there's the treatment of all these tropical diseases, as well as learning about the preventive medicine aspects of this, which forward medics need to be empowered to be able to do, because like I think you're probably suggesting it before, we learn all these lessons from conflict, then we forget about them before the next one. So we need to keep pushing that knowledge.
Well, let's dive a little bit further into the specific implications of conflict in the Pacific theater. And you mentioned tropical diseases, the environment, the jungle environment, the littoral or maritime environment in the archipelago north of Australia. What historically can you point to from Australia's history in World War II, for example, in terms of both DNBI and the environmental impacts on those soldiers in terms of being able to survive war wounds?
Yeah, well, even conventional forces as well as the special operations forces within World War II had to deal with all this stuff. And there was significant debilitation of the patients from malnourishment, from tropical diseases, so malaria, dengue fever, all to a certain extent, some would argue preventative, but in this environment, trying to prevent it is very, very difficult. So that's within the military forces as well as the local population that you're also supporting. And so I think Slim was, he was pretty famous before he went back into Burma, he organised all his medical forces because he had less medical assets than, say, the European theatre or the African theatre, and he was getting more casualties from malaria, etc. So, yeah, there's significant implications for us, both in terms of the condition of the patient. So if you've got a febrile, malnourished patient, they're going to be more difficult to anaesthetise, they're going to be more unstable, and then the post-operative phase, they're less likely to heal. So you now have a position where post-operatively you don't have the proper ward set up and you're not able to the surgeon's not able to go along and do their daily ward rounds. They're being looked after by an auxiliary member perhaps in a village. The surgeon might never actually see them or might just get a note about how they're doing, and they're at a high risk of having wound breakdown and debilitation, which will affect their rehabilitation. And I think that's rehabilitating these people is vital because it's a very limited resource. If we're talking about the worst case with, say, unconventional warfare and looking at irregular fighters, these fighters are limited in number, so everything we do to try and get them back onto the fighting line is vital for us.
That gets back to the moral injury, right, Tom? I think that's where you might be going here is, the issue of crisis standards of care, expectant or palliative care, and the dilemma that medical providers are going to face when there are a limited number of insurgents to carry on the fight. And there are people that you would, as a doctor, you would love to see them moved to the rear and get excellent medical care, but they need to be patched up to the extent that the combatant commander can put them back in the fight, even if they have not been moved through a proper treatment program.
Yeah, I mean, it sounds pretty miserable, doesn't it? If you've got significant amount of your surrogate or your partner force and your own force being affected by these background medical problems plus injury, it really is not a happy place to be. My own grandfather had malaria and dengue fever in World War II, and those diseases affected him for many years afterwards. It's so obvious that the power of the fighting force is going to be hugely degraded by these medical problems that are endemic to the regions. We, in Australia, people, particularly your American listeners, might think we're all experts in this stuff, but the bulk of our population lives to the south of our country where it's nice and temperate and certainly not tropical at all. We do have some world-leading experts in the north, but the population centers there are quite small. So I don't think the bulk of our medical workforce is not well-trained in tropical diseases, and it opens a really good opportunity to have that two-way street between our partner forces and our forces in terms of learning from each other. I mean, I believe in Australia, we offer outstanding levels of medical care, like top of the world sort of stuff. And we can't be too arrogant. Having just said that, I think we need to think that we've got a lot to learn. And I would love to spend more time in these areas learning about the surgical implications of tropical disease, because it's something that I think I could definitely benefit from. And certainly these are they're all two-way streets. I'll share one thing that I've presented on before and I've got an interest in is the Australian prisoner of war experience. And if you look at the Thai-Burma Railway, where there was tens of thousands of Australians of prisoners of war sent by the Japanese after the fall of Singapore, amoebic dysentery in this area was rife, and it killed tens of thousands of people. And people had no way of treating it. Metronidazole hadn't been invented as an antibiotic, and people were at a loss with all of these soldiers just getting diarrhea and dying. And there was a very interesting thing that happened where a few surgeons kind of came up with a creative solution where they were making these stomas in the right colon through an appendicostomy or cecostomy, and they're actually flowing water, like often just boiled river water, through these people's colons to make a colonic lavage, or just kind of irrigate the colon where they felt the bulk of this disease was. Weary Dunlop, who's a pretty famous Australian surgeon, was one of the pioneers of this surgery, and it was hotly debated at the time, and the physicians thought it was a bit rogue. Certainly, it seemed they actually, in amongst this unbelievable hardship, they ran clinical trials during, as captive prisoners of war. They actually ran these
in a
trials.
PW camp running a clinical trial.
They did. Well, I guess. Yeah, I'll talk more on that in 1 second, but they ran these trials and the surgeons felt it worked. And the physicians were skeptical, and it caused some big debates, I think. What I'll say about
physicians being internal medicine providers for our US listeners.
True. Look, I'll make one point on that. The trials thing is super interesting because I was astounded reading that they tried to apply a scientific method to this in situations where over a third of people died.
Publish or perish.
Yeah. Like, it comes down to governance, right? And governance is a very interesting concept. And I think the more how can I put it? The more of a leadership position I have, the more I realize it is actually, so it's kind of defines how we provide care in all circumstances, including in resource deplete warfare environments. If we don't know what we're doing works, we shouldn't be doing it. And I don't want to. So there's sometimes a bit of a perception with some of the stuff we're talking about that it's a bit, you kind of have to make it up. Like, it's low resource, therefore you've got to use innovation, and you've got to just make things up and do what you can. And that's all well and good. And I guess you do have to be innovative always, but you also need to be professional. Like, if you're going to do things that aren't standard care or that you don't know if they work, you do really need to have some sort of governance system, which means tracking outcomes. And in the environment we're talking about, that governance is incredibly difficult. Most of the patients, from what I can see in World War II examples, were lost to surgical follow-up. So they'll have an operation, they'll be moved on to a different space, and whoever did the operation is not going to be looking at them, and there's going to be no capturing of data across the system, which will increase moral injury if we're doing things that we're not sure if they're futile, if they're working. And I think that capturing of data needs to be a key thing.
And you got to look at it as well with in terms of security issues. Like, if you're capturing data, you've got to somehow allow that data to be, I guess, made safe should it fall into enemy hands.
That's true. The final point is offering a legitimate medical care. If a key part of any resistance is confirming or pushing for the legitimate government of that region to be restored. And we therefore need to provide medical legitimacy. And any medical legitimacy is going to come from showing that what we're doing is professional, that we're accountable for our actions, that we're providing value to the people we're working with. And I think that governance underpins all of those things. So in terms of providing a legitimate medical care that's going to prop up the legitimacy of the ruling authority of that region, governance through data capture is going to be key.
Yeah, and that goes to all forms of regular warfare, like going back to foreign internal defence. if you're going to go send an Australian physician into another nation supporting foreign internal defence, they've got to have certification, registration. There's issues with potentially medico-legal stuff. So that's all got to be covered, and it's a bit, all the boxes ticked. I think stepping back to the Pacific area and tropical diseases, the other thing is that the medical providers will be affected by this stuff as well. So, you're going to have a debilitation of your surgical teams, your forward medics, etc. That they're not averse to getting malaria, dengue, etc. Back with our Timor experience, which it doesn't seem that long ago. It's now 25 years ago. After about 2 months, I was down to 50 kilos with my boots on. Though I didn't realise I was becoming malnourished, but clearly I probably was, just because it was busy, it wasn't time to eat, it was hot, and there was lots of stuff going on. And so we've got to educate our providers before they go into that space to look after themselves as well as looking after their patients.
Yeah, we need to convince commanders that preventative medicine is just another form of pulling security for the team.
Oh, look, I had a senior officer at the time who liked to lounge around in his VB singlet. Shout out to the beast if you're listening. Trying to get him to put on long sleeves at night was very difficult.
Hey guys, as we're winding down,
VB is Victoria Bitter. So if you come out, another plug for ATMC, you come out to ATMC, Tom or I might shout you a VB.
I've always thought it tastes like urine, so I didn't drink it myself.
And the question is, how do you know it tastes like urine? But I'd like to wrap this up, if we could. Something that both of you brought up earlier in the discussion is, how do we create, generically, how do we create capabilities to manage medical care in this environment? So where do we go with training, exercise? How do we take providers that are down in Victoria, down in Melbourne, in a nice temperate environment, and get them to learn the lessons from their counterparts that are working up in the Northern Territories, up in Darwin, or our allies and partners further north? How do you educate Americans who aren't exposed to these sorts of environments? How do we take all of this and put it into the IW environment? Any thoughts on training and education as we wrap this up?
I think this is important for commanders. They see this as important issues, and so hence why we're having this discussion. But it boils down to individual and collective training. Individually, if you're a Australian medical provider, you need to be looking at the areas. So you need to be looking at all these diseases that we've been talking about, how it's treated, and buffing up on how to do it. Collectively, I think Tom and I have spoken about how to instill some sort of a program. So I think doing a tabletop exercise with a bunch of specialists where they're looking at what equipment they need, the logistics of it, what type of medical scenarios they could do and how they would do them. So not a tabletop exercise specifically looking at the logistics side of things is worthwhile. Exercising it, so exercising smaller surgical teams in these type of injuries so that we're not doing the same gunshot wound to the belly, gunshot wound to the chest, amputated leg from IED. We're not dealing with those sort of things. We're more dealing with the type of injury patterns that have been seen in the past with these type of conflicts and exercising the surgical teams in those. And that's probably a pretty cheap exercise to do. I've been involved with University College Cork, who have run training for NATO in this sort of stuff. We've run a bunch of small surgical teams through this sort of training, and the surgical teams have got a lot out of it. The trainers have got a lot out of it. So I think we need to be looking at doing that sort of stuff, at those sort of exercises. And finally, learning. As Tom said, we can learn a lot from our partners in the area. So going into these areas with humanitarian assistance, secondments, sabbaticals, that way we can learn from them in terms of treating these tropical diseases, tropical illnesses, work out what the issues are in their population, get a feel for their medical support in that country, so that if their country was in conflict, we already know who the providers are, what their hospital setup is. And we also know whether they are aligned with our values and our government's values, I suppose. So knowing who's who is important, and then maybe even having some sort of secondment for people in the area to come to Australia as well, so that we can share that knowledge. So like fellowships in Australia, having a Fijian surgeon come out and do a fellowship in Liverpool Hospital, perhaps. These are sort of bigger government things to think about, perhaps. But that's just sort of spitballing my thoughts on it. And clearly I'm talking from Martin's perspective. I'm not talking about the Australian government's perspective on it, or the Australian Army's perspective.
But what I'm hearing you say is what I've heard from many practitioners, is that continuing investment in soft power projection is an investment in our preparedness, in our capabilities for other types of operations, building the network, expanding our knowledge, exchanging information. It all goes to make us better no matter what the situation that we face. Tom, I'd like you to wrap this up. Do you have any closing major takeaways as a trauma surgeon on how we have to change our approach when delivering quality surgical care in the Indo-Pacific theater in an irregular warfare environment? What are your one or two big key takeaways?
Gosh, that's a hard one to.
You do a podcast.
Put you on the spot.
Quickly answer.
But
look, I think if I could, the quickest thing I'd say is that no one trade group will have the solution to that question, and forming collaborations at a planning level is key. So I can have all of my medical thoughts and my medical planning thoughts, but they're not very useful in isolation without our logistics medical officers being heavily involved in that discussion, and our nursing officers also being involved, because all those things are the same thing. And we all look at it from different perspectives. Explaining some of the stuff that I'm trying to talk about with what you do surgically, what you do medically, the type of resources you need is different for each of those types of irregular warfare, for each environment. You can't expect a non-medically trained logistics officer to be able to preempt those things. So I think if we're going to roll out successful surgical support to irregular warfare in the Indo-Pacific, it'll need to be a collaborative approach, bridging the clinical and the planning. And we have the medical knowledge we need. We can bolster that up, looking at our partner forces to add what they know that we don't know, apart from endemic disease points of view. But I think, to summarize, it would be collaborative planning.
Excellent. Well, gents, I think we're going to have to wrap it there. I'd also like to point out to our audience that we've also, as part of this short series, had a discussion with Dr. Noel and Grummers, a senior medic, on the role one, or the point of injury view on these topics. So I urge you to listen to that presentation as well. Earlier, it was brought up the idea of post-op care by the auxiliary. We had an interview with Dr. Missy Givens about her role in creating a prolonged casualty care guide for laypersons. That is part of the solution, I believe, as well. So there's a lot to consume here. We hope that you take a look at what we've done on the MSIW podcast. Also, take a deep dive into the back catalog of the PFC podcast, where a lot of these topics have been discussed in interviews with Dennis Jarima. And I hope that you'll continue to stay tuned and subscribe to our podcast. Stay connected with this topic. Take very good care of yourselves, your teammates, and your casualties. And we will see you at the next one.
Thank you for listening to this MSIW program. and we hope that you will both participate and contribute to the notes or offer thoughts, requests, and suggestions via our email link. The best to you, your work, and the relationships and security this effort strives to impact.